Okay, let's unpack this. We're diving into a class of pharmaceutical agents that, on the surface, seem entirely simple. They make you, well, expel water.
Right.
But their mechanisms are so intricately linked to the physiology of the kidney that mastering them is foundational to understanding everything from hypertension to heart failure and even, neurological emergencies.
Indeed. To call them mere water pills fundamentally underestimates their sophistication. Diuretics are precision inhibitors of renal ion transporters.
Okay.
They decrease sodium reabsorption, and water passively follows that sodium into the urine by osmotic gradient. But the true mastery, the elite professional knowledge, lies in understanding that the drug's efficacy, its unique clinical applications, and its entire side effect profile are 100% determined by where along the nephron it lands.
That is our mission today. You've shared an extensive map of the renal system and the drugs that manipulate it, and we are going to trace the path of ions and water through the 5 functional zones of the nephron. We are aiming for absolute mastery, understanding not just what these drugs do, but the cellular and molecular why uncovering, why some are called low ceiling, and why others provide systemic benefits at doses that don't even cause diuresis.
Exactly. We'll explore the precise location of the ceiling effect for one class, the reason one drug prevents kidney stones while its stronger cousin treats life-threatening hypercalcemia,
Right, those opposing effects.
and how the competition for a single transport system in the proximal tubule dictates the risk of gout for almost all common diuretics. It's fascinating stuff.
Absolutely. Let's dive in. Let's begin by appreciating the sheer volume of work that the kidneys handle. Every day, the kidneys filter the entire plasma volume many times over.
It's staggering, really.
Our sources note that approximately 16% to 20% of the blood plasma is filtered into Bowman's capsule.
Right, and this filtrate is essentially plasma minus the large stuffed proteins and cells.
So it contains all the low molecular weight components, glucose, amino acids, bicarbonate, and our critical electrolytes like Na plus K plus CO and
Precisely. And the challenge is taking that massive volume, which could be, 180 liters of filtrate per day,
wow.
and recycling 99% of it to maintain fluid and electrolyte homeostasis. This process unfolds across the 5 functional zones of the nephron, which we must treat as our battlefield, so to speak.
The battlefield. I like that.
Because the degree of diuresis is entirely proportional to the amount of sodium reabsorption we can block at that zone, and critically, how much the subsequent zones can compensate.
Okay, so starting at zone 1, the proximal convoluted tubule, the PCT. I think of this as the bulk processing plant.
That's a good analogy. It's a high-capacity recycler designed for mass retrieval. The PCT is incredibly porous and handles the largest amount of work. Approximately 65% of the filtered sodium and 60% of the water are reabsorbed right there.
65% of sodium, that's huge.
It is. It also recaptures almost all the filtered glucose, amino acids, and bicarbonate. Sodium is moved into the interstitium via the NAT plus K plus AT paste pump on the basolateral side, setting up the gradient for sodium entry on the luminal side. Water just follows passively, maintaining an isotonic environment.
And the reabsorption of bicarbonate here is heavily dependent on carbonic anhydrase, correct?
Absolutely vital. Carbonic anhydrase, or Ca, both on the brush border and within the PCT cell cytoplasm, facilitates the entire process of H+ secretion and subsequent reabsorption of HCO3 bicarbonate.
Okay.
And an important detail here is that diuretics that act here, like the Ca inhibitors, are considered weak agents.
Even though they block where 65% of sodium reabsorption happens, they're still weak. This is the crucial concept of downstream compensation, isn't it?
Precisely. That's the key takeaway. If a diuretic leaves sodium and water behind in the PCT lumen, there is a massive high-capacity compensatory mechanism waiting just down the road, the loop of Henle.
Wow.
The loop will simply mop up and retain most of that residual sodium and water, severely limiting the total effective increase in urine output.
So to be a powerful diuretic, you must act downstream of, or maybe within, the loop itself.
Exactly. You have to get past that major compensatory point.
Let's not overlook the crucial detail of the secretory systems in the PCT. You mentioned this is where many of our drugs physically enter the tubular fluid.
Yes, this is a key pharmacological point that dictates therapeutic efficacy and, importantly, interaction warnings. The PCT contains active transport systems that move substances from the bloodstream into the tubular lumen.
Okay, actively pumping them in.
Right. We have the organic acid secretory system located primarily in the middle third, and the organic base secretory system in the upper middle segments.
And diuretics fall into one of those.
All major diuretics, thiazides, and loops are organic acids and must be secreted via this system, the organic acid system, to reach their respective sites of action downstream, the DCT and the loop.
If they rely on this system, and you said the system is saturable, that creates competition, right?
It creates a tremendous competition, especially for the organic acid transporter, the OAT. Diuretics, being massive organic acids themselves, compete aggressively for transfer with endogenous organic acids.
Like what?
Most notably, uric acid. This competition slows the kidney's ability to excrete uric acid, leading to elevated serum levels. That's the primary mechanism behind diuretic-induced hyperuricemia and the associated gout risk we see.
Ah, okay. That makes sense. It's a traffic jam for the transporter.
Pretty much. The historical use of probenicide to reduce the renal excretion of penicillin to prolong its half-life, that's a classic example of how we manipulate this exact same saturable system.
Interesting. Okay, moving on to zones 2 and 3, the loop of Henle, the kidney salt pump. Zone 2, the descending limb, is where the initial isotonic fluid enters the renal medulla.
Right, the descending limb is purely permeable to water, as the fluid descends into the hyperosmotic medullary interstitium, which is made salty by the work of the ascending limb.
Okay.
Water is pulled out, concentrating the tubular fluid up to threefold. This process of water reabsorption is partially inhibited by osmotic diuretics like mannitol, which basically increase the tubular fluid osmolarity, holding water in.
Got it. Then we hit zone 3, the thick ascending limb, TAL, the undisputed powerhouse.
This is the critical site for high-efficacy agents. The cells of the tail are unique because they are impermeable to water, even when highly concentrated with sodium.
Impermeable to water, okay.
Their sole function is the active reabsorption of salt specifically, 25% to 30% of the filtered NaCl via the Na plus K plus 2Cl cotransporter, or NKCC2. Inhibiting the NKCC2 here is the reason loop diuretics achieve the greatest possible diuresis.
Why is blocking 25% to 30% here so much more effective than blocking that huge 65% back in the PCT?
Because there is no major compensatory mechanism downstream capable of handling that massive salt load left behind. The distal segments, the DCT and collecting duct, they only manage maybe 15% or less of the total filtered load.
So the system is overwhelmed.
Completely. Furthermore, blocking the NKCC2 means you prevent the formation of the hyperosmotic medullary interstitium itself.
The saltiness of the medulla.
Right, which is the engine driving the kidney's ability to concentrate urine in the collecting duct later on. So you lose both the salt and the ability to reclaim water efficiently downstream. It's a double whammy leading to maximum volume loss.
Okay, that clarifies the high efficacy concept. Now, on to zone 4, the distal convoluted tubule, DCT. We're now fine-tuning the filtrate.
Exactly. The DCT remains impermeable to water and is responsible for reabsorbing a smaller, but still meaningful 5% to 10% of the filtered NaCl, specifically via the Na plus Cl cotransporter. This is the sole target of the thiazide diuretics.
The thiazide target. And calcium handling is different here.
Yes, what's fascinating here is the distinct mechanism for calcium handling. Ca2 plus reabsorption is regulated by PTH, parathyroid hormone, and involves an apical channel and a basolateral Na plus C2 plus exchanger.
And that exchanger is key for the thiazides you mentioned.
It's precisely what thiazides exploit to retain calcium, which we'll definitely circle back to.
Good. And finally, zone 5, the collecting tubule and duct. The ultimate spigot, maybe.
Yeah, the final control point. This is the final frontier, regulating volume based on systemic signals. Principal cells handle Na plus, K plus gel, and water.
Oh.
Sodium enters via epithelial sodium channels, or ENC, which are the targets for specific K plus sparing diuretics like amiloride. Aldosterone regulates the synthesis of ENC and the Na plus K plus ATPase pump, promoting Na plus reabsorption and K plus excretion. Water reabsorption is entirely dependent on ADH, or vasopressin,
ADH?
binding to V2 receptors to deploy aquaporin channels, letting water out. The intercalated cells, meanwhile, manage pH balance through H plus secretion. It's complex, fine-tuned regulation.
Absolutely. That lays a fantastic foundation. Let's transition now to the thiazides, which are perhaps the most frequently prescribed diuretic class globally, mainly due to their role in hypertension. We established they are low-ceiling diuretics. Let's clarify that term and detail their mechanism again.
Right, the low ceiling designation. It comes from the fact that they only block that 5% to 10% of total filtered sodium reabsorption in the DCT via the Na plus Cl cotransporter. Okay. Once that transporter is fully saturated with the drug, increasing the dose further simply cannot block any more sodium transport. There's just not much capacity there compared to the loop.
So you hit a maximum effect relatively quickly.
Exactly. Contrast this with the loop, which blocks that much larger 25–30% chunk in the ascending limb.
Clinically, why are thiazides so effective for hypertension then, often outperforming loops for that specific indication? They seem weaker based on sodium excretion.
Yeah, it's a great question. Their efficacy is twofold. Initially, yes, they reduce blood volume by modest diuresis, which lowers cardiac output.
Okay, the initial volume drop.
But the chronic antihypertensive benefit, the one that sustains even when volume kind of returns toward baseline over time, is due to their ability to reduce peripheral vascular resistance, PVR.
They relax the blood vessels.
We think so. It seems to be a direct vasodilator action, possibly by decreasing the sodium content of vascular smooth muscle cells, which makes them less sensitive to vasoconstrictors like norepinephrine. This PVR reduction is crucial for long-term BP control, and it's something loop diuretics don't do as effectively long-term.
Got it. Key agents include chlorothiazide and the more potent hydrochlorothiazide. But the thiazide-like agents, clothalidone, indapamide, and metalazone, are gaining prominence, you said.
They are critical. They lack the specific benzothiadiazine chemical structure, but share the exact same mechanism of action blocking that Na plus Cl cotransporter in the DCT.
And clothalidone is often preferred.
Yes, especially by, experts in hypertension management. Its half-life is significantly longer, up to 60 hours, compared to maybe 615 for hydrochlorothiazide.
Wow, that's a big difference.
It is, and it provides superior, more sustained 24-hour blood pressure control. Metalazone is also unique because it retains its efficacy down to lower glomerular filtration rates, unlike most other thiazides. That makes it useful in combination therapy for patients with moderate renal impairment who might be resistant to loops alone.
And we must revisit that essential requirement. For any diuretic effect, thiazides must be actively secreted into the PCT lumen via that OAT system we discussed.
Absolutely critical.
Which means reduced renal function severely limits their diuretic action, though maybe not the BP effect.
Correct. When GFR falls below roughly 30 lmin 1.73 milli2, the amount of drug reaching the DCT lumen drops significantly, diminishing the diuretic effect. You just don't get much water loss. But importantly, they can often maintain their PVR reduction and antihypertensive benefit even at lower GFRs. So we don't necessarily discontinue them immediately for hypertension just because GFR drops, but we might need to switch to a loop diuretic if volume control becomes the primary goal.
Okay, that distinction is key.
Yeah.
Now for the unexpected clinical benefit, the calcium retention. How does blocking a sodium chloride transporter lead to less calcium in the urine? It seems unrelated.
It is a beautiful piece of cellular pharmacology, really. By blocking the Na plus Cl cotransporter in the DCT, thiazides decrease the amount of sodium entering the cell from the lumen.
Okay, less sodium inside the cell.
Right. This lowers the intracellular sodium concentration. Now remember that basilateral Na plus CaO2 plus exchanger. It uses the energy stored in the sodium gradient, high outside, low inside, to pump calcium out of the cell and into the bloodstream in exchange for sodium coming in.
Okay, I follow.
When intracellular sodium drops because of the thiazide, this exchanger works harder and faster to bring sodium in. And to do that, it has to pump more calcium out.
So it pulls more calcium from the tubular fluid through the apical channels into the cell, just so it can be pumped out into the blood by the hyperactive exchanger.
Precisely. The net effect is enhanced calcium reabsorption from the filtrate back into the body.
So, by promoting calcium reabsorption and decreasing urinary Ca2 plus excretion, they are the drug of choice for patients suffering from recurrent calcium oxalate kidney stones due to idiopathic hypercalciuria, meaning they just spill too much calcium in their urine.
Exactly. It's a major therapeutic niche for thiazides. This mechanism, however, also explains the potential adverse effect of mild hypercalcemia, especially if someone already has borderline high calcium or takes supplements.
Right. The benefit and the risk spring from the same mechanism. Fascinating. The second unique benefit is their efficacy in diabetes insipidus, which, as you noted, seems totally counterintuitive. Why does a diuretic decrease urine output in a condition defined by excessive urine output?
It's complex, and it involves inducing a mild state of volume depletion. Thiazides cause a slight reduction in total body sodium in water.
Okay.
This mild volume depletion signals the kidney, particularly the PCT, to increase its reabsorption of salt and water further upstream. It's like the kidney is trying to compensate for the perceived fluid loss.
The more fluid gets reabsorbed before it even reaches the collecting duct.
Exactly. This reduces the amount of fluid delivered to the collecting duct, which is the segment that's insensitive to ADH in nephrogenic diabetes insipidus. Less fluid arriving means less urine produced overall. Plus, the mild hypovolemia might also increase ADH release slightly, which helps in central DI.
So the net result is that the patient produces a significantly more concentrated hyperosmolar urine, drastically reducing the total urine volume. That's quite elegant.
It really is. They can cut urine output from, say, 11 liters a day down to 3 liters. Invaluable for treating nephrogenic DI.
Okay, let's detail the electrolyte hazards, starting with hypokalemia, low potassium.
This is probably the most common side effect and requires monitoring. By blocking sodium reabsorption higher up in the DCT, the thiazides dramatically increase the sodium load presented downstream to the aldosterone-sensitive collecting tubule.
More sodium arriving there.
Right. This forces the principal cells in the collecting duct to exchange that excess sodium for potassium and also hydrogen ions using those ENAC channels and the Na plus K plus pump at an accelerated rate.
So you waste potassium.
You waste potassium, potentially leading to significant K plus loss, hypokalemia, and potentially contributing to a slight metabolic alkalosis because you're also losing H plus ions in exchange for sodium.
And back to that competitive transport system in the PCT.
Yeah.
The hyperuricemia and resulting gout risk. We need to stress this again for mastery.
Yes, absolutely. This is not some peripheral effect. It's central to the drug's fate in the kidney. Thiazides acting as strong organic acids compete with and saturate the OAT system in the PCT,
Blocking uric acid secretion.
blocking the active secretion of uric acid into the lumen, causing uric acid levels in the blood to rise. If the patient has a genetic predisposition or other risk factors for gout, this is a powerful trigger for gouty arthritis. Caution and monitoring are essential.
Finally, the risk of mild hyperglycemia, high blood sugar. What's the best current understanding of that link? Is it definite?
It's generally accepted, though perhaps not a huge effect for most people. The risk seems tied to the electrolyte imbalance, specifically the hypokalemia we just discussed.
How does low potassium affect sugar?
Well, potassium is essential for normal insulin secretion by the pancreatic beta cells. When K+ levels drop too low due to the thiazide, this can impair insulin release in response to glucose.
Okay.
This can potentially cause slightly elevated blood glucose levels or make existing diabetes harder to control, so it requires careful monitoring, especially in diabetic patients or those at risk. Other potential issues are hyponatremia and hypomagnesemia, too. Okay, now we move to the high-efficacy agents, the loop diuretics. These include furosemide, bumetanide, torsemide, and the historically important but less used now due to side effects, ethacrynic acid.
Right. And when rapid maximal fluid mobilization is required, like in acute heart failure, these are the heavy hitters.
Absolutely. They are the go-to drugs for significant volume overload.
The bioavailability distinction you mentioned earlier is crucial for clinical practice. Why is furosemide the most common agent, often suboptimal for oral use specifically?
Yeah, furosemide's oral bioavailability is wildly unpredictable. Studies show it can range anywhere from 10% absorption up to 90%.
10 to 90. That's huge variability.
It is. It means you can't guarantee a patient is absorbing a consistent dose day to day or patient to patient. In contrast, bumetanide and torsemide offer highly reliable oral bioavailability, much tighter range, closer to 80% to 100%.
Much more predictable.
Much more predictable. So for reliable oral therapy in chronic heart failure or persistent edema where you need consistent effects, those two, bumetanide and torsemide, are often preferred over oral furosemide. However, furosemide is fine, of course. Bioavailability isn't an issue then.
Okay, let's lock in the mechanism and why they deserve the title highest efficacy.
It's all about the site, right?
It's all about the site. They inhibit the Na plus K plus 2Cl cotransporter and KCC2 in the luminal membrane of the thick ascending loop of Henle. As we discussed, this segment normally reabsorbs a massive 25% to 30% of the filtered sodium chloride.
Blocking this incredibly high-capacity segment is immensely effective because, again, it completely overwhelms the limited compensatory capacity of the DCT and collecting duct downstream. There's just no way for the rest of the nephron to reclaim that much salt.
And they share the same secretory requirement as the thiazides, right? They must be secreted via the OAT system in the PCT, to reach the loop lumen.
Yes, that's correct. They are also organic acids. This linkage means that loops are also susceptible to diminished efficacy in severe renal impairment.
Because they can't get secreted effectively.
Right. And they're also susceptible to interference by NSAIDs like ibuprofen or naproxen.
Why NSAIDs?
NSAIDs inhibit renal prostaglandin production. Prostaglandins normally help maintain renal blood flow and glomerular filtration. By inhibiting them, NSAIDs can reduce blood flow to the kidney, which reduces the delivery of the loop diuretic to the PCT for secretion, and also impairs the diuretic's direct action. So NSAIDs can blunt the effect of loop diuretics significantly.
Good practical point. Let's analyze the sigmoidal dose-response curve you mentioned. It looks like an S shape. This curve perfectly explains why modifying the frequency rather than just endlessly increasing the dose is often the proper strategy.
Yes, understanding this curve is essential for dosing mastery with loop diuretics. It has 3 distinct parts. First, you must hit the threshold effect. Below a certain dose or concentration in the tubule, you get essentially 0 diuretic action.
Okay, got to reach the minimum effective dose.
Right. Then you enter the steep part of the curve, the rapid increase phase. Here, small increases in drug concentration yield large increases in sodium and water excretion. This is where you see the main therapeutic effect.
And then it flattens out.
And then it flattens out at the top. This is the ceiling effect, often known as the maximum effective excretion rate or transport maximum for that segment. Once you hit this point, the NKCC2 transporters are maximally inhibited, or the delivery of sodium to the site is maximal.
So giving more drug doesn't help.
Giving a higher single dose doesn't result in more salt and water being excreted per unit time, because the system is physically saturated or overwhelmed. It only results in higher peak drug concentrations in the body, which can last longer, but importantly, also exacerbates dose-dependent side effects like ototoxicity.
So the professional takeaway is clear. Find the dose that hits that ceiling for the individual patient, the dose that gives a good response.
Exactly.
And then, if you need more total fluid removal over the day, you increase the frequency of that effective dose, give it 2 or 3 times a day, rather than just doubling or tripling the single dose itself.
Precisely. If a patient is refractory to, say, 40 milligrams of IV furosemide, giving 80 milligram IV as a single dose won't necessarily achieve much more immediate diuresis than giving 40 milligram IV now and another 40 milligram IV a few hours later. But the 80 milligram single dose carries a higher risk of side effects.
Makes perfect sense. Beyond treating chronic edema, loop diuretics are the drug of choice for acute situations, particularly pulmonary edema. This is partly due to their rapid, non-diuretic effect of venodilation. Can you explain that?
Yes, this is a crucial life-saving mechanism that occurs within minutes of IV administration, often before the patient has even produced significant urine. Loop diuretics seem to enhance renal and possibly systemic prostaglandin synthesis.
Prostaglandins again.
Yes, and these prostaglandins cause immediate, profound venodilation. This means the veins relax and hold more blood.
Which does what?
It lowers systemic venous capacitance, effectively reducing the amount of blood returning to the heart, the preload. This rapidly decreases left ventricular filling pressures and pulmonary congestion. It provides symptomatic relief in acute pulmonary edema, sometimes dramatically, well before the diuretic effect really kicks in to remove the excess volume.
Wow, that's fast acting. Now, in terms of electrolyte management, they're used for 2 conditions where they have the opposite effect compared to thiazides: hypercalcemia, high calcium, and hyperkalemia, high potassium.
Absolutely. Unlike thiazides, loop diuretics actively increase urinary calcium excretion. They cause calciuria. By inhibiting the NKCC2 transporter, they disrupt the generation of the positive electrical potential in the lumen of the thick ascending limb. This positive potential normally drives the passive paracellular reabsorption of divalent cations like calcium and magnesium between the cells.
So blocking the transporter kills that driving force.
Exactly. Without that positive luminal potential, calcium and magnesium reabsorption is significantly reduced, leading to increased excretion in the urine. This makes loop diuretics indispensable, alongside aggressive IV hydration, for flushing excess calcium out in acute, life-threatening hypercalcemia.
And for hyperkalemia.
Likewise, their profound promotion of sodium delivery to the collecting duct drives significant potassium excretion via that sodium-potassium exchange mechanism we discussed earlier. This makes them a fast option, often used with other therapies, for lowering dangerously high serum potassium in hyperkalemia emergencies.
Okay, now to the adverse effects. The 2 major risks seem to be massive fluid shifts and ototoxicity, hearing damage.
Yes. The risk of acute hypovolemia is inherent in their high efficacy. Rapid THAI administration, especially of large doses, can lead to excessive fluid loss, causing hypotension, dizziness, and even shock if not monitored carefully.
And the ototoxicity, how does that happen?
It seems to involve damaging the stria vascularis in the cochlea of the inner ear. This structure is responsible for generating the potassium-rich endolymph and the electrical potential crucial for hearing function. The NKCC transporter is actually present there too.
Ah, so the drug might affect it there as well.
That's the thinking. The risk is highest with very fast 4B infusions, extremely high doses in patients with renal failure as drug levels get higher, or importantly in patients concurrently receiving other ototoxic drugs like aminoglycoside antibiotics or potentially high-dose salicylates.
Is it permanent?
It can be, unfortunately, though sometimes it's reversible if caught early and the drug is stopped. It's a severe clinical risk that necessitates careful administration. And it must be noted that ethacrynic acid, the one non-sulfonamide loop diuretic, is generally considered the most likely loop diuretic to cause ototoxicity.
Good to know. And finally, we reiterate that, like thiazides, loop diuretics carry a significant risk of hypokalemia and metabolic alkalosis due to the massive distal delivery of sodium-driving K+ and H+ loss.
Correct. Often more severe than with thiazides due to the larger sodium load.
And they also contribute to hyperuricemia and gout via competition in the PCT secretory system, just like thiazides.
Yes, that mechanism is shared. They both compete with uric acid for secretion.
Transitioning now to the potassium-sparing diuretics. As the name implies, their main job is often as adjuncts, used with loops or thiazides, specifically to protect the patient from the hypokalemia caused by those more potent agents.
Exactly. They act in the final segment, the collecting tubule and duct, to inhibit sodium reabsorption in a way that retains potassium.
But their critical risk is the converse: hyperkalemia, high potassium. This is especially dangerous in patients with impaired renal function or those taking other drugs that raise potassium, like ACE inhibitors or ARBs, right?
Absolutely. The risk profile is completely inverted. Combining these agents requires extreme caution regarding potassium levels. Their diuretic effect alone is quite weak, but their impact on potassium is significant. We divide them into two main classes based on mechanism.
Okay, class A, aldosterone antagonists, spironolactone and eplerenone.
These are synthetic steroids that directly compete with aldosterone for its mineralocorticoid receptor, MR, in the principal cells of the collecting tubule.
So they block aldosterone's effects.
Precisely. By blocking the binding of aldosterone, they prevent the hormone from doing its job, which is stimulating the synthesis and insertion of more E-Nancy sodium channels on the luminal side and more Na plus K plus ATPase pumps on the basolateral side.
And
the result is less sodium reabsorption and consequently less potassium and hydrogen ion excretion. So you retain K plus and H plus A, leading to potential hyperkalemia and mild metabolic acidosis, while excreting a bit more Na plus and water.
The side effect profile is the key differentiator between the two agents, spironolactone and eplerenone, isn't it?
Absolutely. This is crucial clinically. Spironolactone is the older agent, and it's, well, less selective. It binds not only to the mineralocorticoid receptor, but also significantly to progesterone and androgen receptors elsewhere in the body,
Leading to hormonal side effects.
Exactly. This non-selectivity is responsible for the classic adverse effects: gynecomastia, breast enlargement in men occurring in up to 10% of users, decreased libido, impotence, and menstrual irregularities in women.
And eplerenone avoids these.
Yes, eplerenone is a newer, much more selective antagonist. It has very little affinity for androgen and progesterone receptors, so it avoids these endocrine-related side effects, making it preferable for patients, especially men, who cannot tolerate spironolactone's hormonal actions, though it's generally more expensive.
Let's expand on their non-diuretic role in chronic heart failure. You called this a key aha moment. Why are these used in heart failure, often at low doses that don't cause much diuresis?
This was a landmark discovery in cardiology. In patients with chronic heart failure with reduced ejection fraction, HFrEF, these agents are used specifically to block aldosterone's detrimental systemic effects, independent of volume status.
What effects are those?
Aldosterone, especially when chronically elevated as it often is in heart failure, promotes myocardial and vascular fibrosis. This means pathological scarring and stiffening of the heart muscle and blood vessels.
Which make the heart failure worse.
Exactly. It accelerates the decline in heart function, a process known as adverse remodeling. Low-dose aldosterone blockade with either spironolactone or eplerenone has been shown in major clinical trials, like RALIS and EPHESIS, to prevent this remodeling process.
And the outcome?
Demonstrably decreases mortality and hospitalizations in these patients. It's a cornerstone of HFR-EF therapy now, used purely for its anti-remodeling benefits, not primarily for diuresis at those low doses.
That's fascinating. They're also the drug of choice for managing edema, associated with hepatic cirrhosis and ascites, often alongside a loop diuretic. Why specifically in cirrhosis?
Spironolactone in particular is often the preferred initial agent here because patients with advanced cirrhosis frequently exhibit secondary hyperaldosteronism. Their liver isn't breaking down aldosterone properly, and their kidneys perceive low effective circulating volume, leading to very high aldosterone levels driving the fluid retention.
So targeting that specific hormonal driver is logical.
Exactly. It's the most effective initial strategy. You often need a loop diuretic as well for more potent diuresis, but starting with spironolactone addresses the underlying pathophysiology.
And you also mentioned they're highly effective in treating resistant hypertension.
Yes, this is another key indication. For patients whose blood pressure remains stubbornly high despite being on 3 or more other antihypertensive medications, often including a thiazide, adding an aldosterone antagonist, usually spironolactone first, often provides significant additional blood pressure lowering.
Even if their aldosterone levels aren't obviously high.
Surprisingly, yes. Even in patients with apparently normal aldosterone levels, these drugs frequently work in resistant hypertension. It suggests that inappropriate aldosterone activity, perhaps at the tissue level in the blood vessels, might be playing a role that standard blood tests don't capture. Spironolactone is also used off-label to treat polycystic ovary syndrome, PCOS, in women, leveraging its anti-androgen effects.
Okay, now, Class B, the epithelial sodium channel, ENC blockers, triamterene, and amyloid. How do these differ?
These agents are structurally different from the aldosterone antagonists. They are not steroids. They work by directly plugging or blocking the ENC sodium channels in the luminal membrane of the collecting tubule principal cells.
So they stop sodium entry directly regardless of aldosterone levels.
Exactly. They physically obstruct the channel, preventing sodium entry from the tubular fluid into the cell. This reduces the electrochemical gradient that drives potassium secretion out of the cell.
Are they strong diuretics?
No, they are very weak diuretics on their own, even weaker than the aldosterone antagonist. They are rarely, if ever, used as monotherapy for edema or hypertension,
So what is their primary clinical utility?
almost exclusively for their potassium-sparing effect. They are primarily used in combination products like mexilide or diazide, which combine hydrochlorothiazide with triamterene, or added separately to a thiazide or loop diuretic regimen. Their sole purpose in these combinations is to counteract or mitigate the potassium loss caused by the more potent diuretic, offering a non-hormonal way to help keep potassium levels normal.
Got it. They're basically K+ sparing helpers. Let's move to our specialized classes, starting with the carbonic anhydrase inhibitors, CAI, with acetazolamide being the main example. You said weak diuresis, massive impact on pH.
That sums it up well. The mechanism, as we touched on, is inhibiting the enzyme carbonic anhydrase, primarily in the PCT. This enzyme is crucial for the reabsorption of filtered bicarbonate, HCO3.
How does inhibiting it cause diuresis?
By preventing bicarbonate reabsorption, you leave this major anion, HCO3, trapped in the tubular lumen along with the sodium ion, Na+, that would normally be reabsorbed with it via Na plus H plus exchange. This osmotic effect keeps some water in the tubule, leading to a mild diuresis.
But the big effect is on pH.
Yes, the major consequence is the loss of bicarbonate in the urine. Losing bicarbonate, which is the body's main buffer or base, leads to a buildup of acid in the blood. This results in a characteristic hyperchloremic metabolic acidosis. The urine, conversely, becomes markedly alkaline because it's full of bicarbonate.
So their therapeutic uses focus entirely on those unique non-diuretic mechanisms, exploiting the CA inhibition elsewhere or the acidosis.
Indeed. They're not really used as diuretics anymore. Acetazolamide is a mainstay in treating glaucoma.
How does it help glaucoma?
By inhibiting carbonic anhydrase in the ciliary body of the eye. This enzyme is involved in the production of aqueous humor, the fluid inside the front of the eye. Blocking it reduces aqueous humor production, which rapidly lowers intraocular pressure in acute angle closure glaucoma, or helps manage open-angle glaucoma.
And the other main use.
Its other key use is for altitude sickness prophylaxis. When you go to high altitude quickly, you can develop symptoms like headache, nausea, dizziness, and potentially life-threatening cerebral or pulmonary edema.
How does acetazolamide prevent that?
By inducing that mild metabolic acidosis we talked about, the acidosis stimulates the peripheral chemoreceptors in the carotid bodies, which signals the brain to increase the rate and depth of breathing. This improves oxygenation and helps the body acclimatize faster to the lower oxygen levels at altitude. It needs to be started before ascent.
Interesting. And you mentioned a contraindication.
Critically, it is contraindicated in patients with hepatic cirrhosis. The metabolic acidosis it causes impairs the kidney's ability to excrete ammonia, NH4+. In cirrhotic patients who already have trouble clearing ammonia, this can lead to ammonia buildup and potentially precipitate or worsen hepatic encephalopathy.
Okay, very important point. Our final class, the osmotic diuretics, exemplified by mannitol. This is pure aquaresis, you said, water loss without much salt loss.
Exactly. Mannitol is simple chemistry applied to physiology. It's a sugar alcohol, highly hydrophilic, water-loving, filtered freely by the glomerulus, but it's minimally reabsorbed by the renal tubules.
So it stays in the tubule.
It stays in the tubule, primarily in the PCT and the descending limb of the loop of Henle, which are the segments most permeable to water. By staying in the lumen, it acts as an osmole. It increases the osmolarity or solute concentration of the tubular fluid.
Making the fluid inside saltier or more concentrated.
Right. This high osmolarity directly opposes the osmotic gradient that normally pulls water out of the tubule and into the interstitium. It effectively holds water within the tubule through osmosis,
Resulting in water loss.
resulting in significant water loss, or aquaresis, but very little net sodium excretion. Because it doesn't block sodium transport directly, osmotic diuretics are generally ineffective for managing conditions associated with sodium retention, like heart failure or cirrhosis edema.
What's the primary application for this unique mechanism then? Where do you need pure water removal?
Its primary and arguably most vital use is for rapidly reducing acutely elevated intracranial pressure, ICP, such as after head trauma, stroke, or brain surgery.
How does it pull fluid from the brain?
By increasing the osmolarity of the blood, the extracellular fluid in the brain vasculature. When you infuse mannitol IV, it temporarily makes the blood hyperosmolar compared to the brain tissue. This osmotic gradient pulls water out of the brain parenchyma, the brain cells and surrounding space, and into the blood vessels,
Reducing brain swelling.
reducing brain swelling and lowering ICP quickly. It's a critical intervention in neurocritical care. It's also sometimes used to maintain urine flow in situations of acute toxic ingestion to help flush out toxins, or in the early phases of acute kidney injury to try and prevent tubular obstruction.
And what is the specific danger professional clinicians need to be warned about regarding its administration? There's an initial effect before the diuresis.
Yes, this is absolutely critical to understand. The immediate adverse effect upon infusion is transient extracellular water expansion. Before mannitol gets filtered by the kidneys and starts causing diuresis, it first circulates in the bloodstream and pulls water out of all body cells, including red blood cells and neurons, into the systemic circulation.
So blood volume actually increases initially.
Yes, this initial fluid shift increases the intravascular volume and can dilute the blood sodium, causing transient hyponatremia. More dangerously, this rapid expansion of blood volume can acutely worsen heart failure or precipitate pulmonary edema in susceptible patients before the beneficial diuretic effect kicks in. Careful monitoring is essential during administration. Dehydration is also a risk if fluid losses aren't replaced.
Okay, here's where it gets really interesting. Synthesizing these distinct mechanisms into clinical decision-making. We've established two major contradictions, almost paradoxes, that differentiate these drugs in practice.
Yes, these are crucial for mastery. The first is the calcium paradox. We established that thiazides, like hydrochlorothiazide or chlorthalidone, cause calcium retention by enhancing the non-plus KT2 plus exchanger in the DCT.
Making them ideal for long-term prevention of calcium oxalate kidney stones in patients with hypercalciuria.
Exactly. Conversely, loop diuretics, like furosemide or bumenide, cause profound calcium excretion by disrupting the salt gradients and electrolyte potential in the loop of Henle.
Making them essential, alongside hydration, for the acute treatment of life-threatening hypercalcemia. Totally opposite effects on calcium.
Completely opposite. Knowing which drug does what to calcium is fundamental.
The second critical point to synthesize is the shared gout risk, stemming from that saturated organic anion transporter system back in the PCT.
Right. It's crucial to remember that both thiazides and loops can cause hyperuricemia and precipitate gout attacks. They both act as organic acids that compete with uric acid for secretion via the OAT.
So you can't just switch from a thiazide to a loop hoping to avoid the gout risk.
No, generally not. The risk is inherent to both classes due to that shared secretion pathway. It's often an unavoidable consequence of using these powerful volume-managing drugs in predisposed patients, requiring concurrent management of the hyperuricemia itself, perhaps with drugs like allopurinol if needed.
Let's discuss the synergy of combination therapy, especially in situations like diuretic resistance or complex diseases like heart failure. How are these drugs used together?
Combination therapy is key when a single agent isn't enough. For diuretic resistance, typically seen in patients with advanced heart failure, severe renal impairment, or nephrotic syndrome where they become less responsive to loop diuretics alone.
Yeah, what do you do then?
A common and often very effective strategy is sequential nephron blockade. This involves adding a thiazide-type diuretic, often metolazone because it retains efficacy at lower GFRs, or sometimes even high-dose hydrochlorothiazide, to the loop diuretic regimen.
So you block the loop and the DCT.
Exactly. You block sodium reabsorption at two different major sites along the nephron. This synergistic effect often overcomes the kidney's compensatory mechanisms that were limiting the response to the loop diuretic alone, allowing for significant controlled fluid removal. It needs careful monitoring, though, as the electrolyte losses can be profound.
And the other key combination, a loop diuretic with an aldosterone antagonist in heart failure.
Yes, that combination is the epitome of professional synthesis and guideline-directed medical therapy for HFrEF. A loop diuretic, like furosemide or bumetanide, is used as needed for managing congestion and maintaining volume balance.
Okay, for the fluid.
While the aldosterone antagonist, like spironolactone or eplerenone, is used chronically, usually at lower doses, serving that dual, equally vital function we discussed.
What's his?
1, mitigating the often severe potassium and magnesium loss caused by the high-dose loop diuretic the patient might need. 2, and arguably more importantly for long-term outcomes, providing the non-diuretic, antifibrotic, anti-remodeling action that prevents the progression of heart failure and reduces long-term mortality. It's treating both the symptoms and the underlying disease progression.
Brilliant. Finally, reiterating the finding regarding resistant hypertension, the surprising effectiveness of aldosterone antagonists there.
Yes, it's a really important clinical pearl. For patients whose blood pressure remains stubbornly high despite being on 3 or more antihypertensive medications from different classes, typically including a thiazide diuretic, an ACE inhibitor or ARB, and a calcium channel blocker, the fourth drug added is often an aldosterone antagonist, particularly spironolactone.
And it often works.
It often yields surprising success, providing significant additional blood pressure reduction where other drugs have failed. And as we mentioned, this benefit is seen even in patients whose plasma aldosterone levels are not overtly elevated according to standard lab tests.
Suggesting a mechanism beyond just blocking high aldosterone levels.
Exactly. It suggests that perhaps inappropriate aldosterone activity at the tissue level, maybe in the blood vessel walls promoting stiffness or vasoconstriction or effects on sodium handling, contribute significantly to resistant hypertension, and blocking that pathway is key, even if systemic levels look normal. #tag outro.
We have completed a really dense journey today. We've mapped the renal system and hopefully internalized the precise mechanism and profile of 6 fundamentally distinct classes of diuretics.
Yeah, quite a tour of the nephron.
And true professional mastery, as we aimed for, means moving beyond just memorization of names and doses. It's about understanding the underlying chemical rules, the osmotic forces, the active transport gradients, the receptor selectivity that govern fluid and electrolyte balance at a cellular level.
Absolutely.
Because that understanding allows us to accurately predict drug synergy, anticipate risks like hyperkalemia or hypokalemia or gout, and identify the specific patient populations for whom these drugs offer those unique, sometimes non-diuretic, life-saving benefits.
And that level of predictive knowledge leaves us with a necessary clinical dilemma. A final thought, perhaps. We noted that thiazides, which have that nice side effect of protecting bone health by retaining calcium, unfortunately lose their diuretic punch when the glomerular filtration rate drops significantly in chronic kidney disease.
Right, forcing clinicians to switch.
Exactly. Clinicians are then often forced to switch to high-efficacy loop diuretics for essential volume control in those CKD patients, but in doing so, they risk aggressively depleting the patient's calcium stores, promoting calciuria, which is detrimental to bone health, already a major concern in chronic kidney disease patients who often have complex mineral and bone disorders.
So it's a trade-off.
It's a real trade-off. How might we optimally balance the immediate critical need for aggressive fluid removal using loops with the long-term imperative of preserving fragile mineral balance and skeletal health in this very vulnerable population? It's a constantly shifting therapeutic tightrope that requires careful thought and constant recalibration based on the individual patient status.
A perfect question to keep mulling over as you reflect on the intricate rules governing the nephron and the drugs that manipulate it. Thank you for diving so deep with us today.